Hi everyone, I am Dr. Sagar Sahu and welcome to Veterinary. So today I welcome you to another lecture in the series Orthopedics. Today we will be discussing the fracture reduction. I have already made 3 videos before this one. If you have not watched those, please do watch. I will give the link of the playlist in the description. Okay, so today we will be discussing regarding the fracture reduction. Before going to the lecture, if you are new to this channel, please do subscribe to this channel. You will never be disappointed. Okay, and if you are watching this channel but yet not subscribed, please do subscribe. Apart from YouTube, in the Facebook I do post different surgeries pictorially. Important one is actually Instagram. In Instagram I post regarding the upcoming videos. I also post the notes. I also post some interesting case reports also, so you can watch them. Okay, do follow me in the Instagram, especially for notes. Now regarding the book which I am following this Small Animal Surgery by Possum, Theresa Wells Possum. Okay, this is a very good book. I will give the link to this particular book, Google Drive link, in the description, as well as I will also provide the link to this particular PPT as well as some handwritten notes in the description. Okay, so we don't need to take any notes in this class, just listen. After that, simply revise from the notes in the Google Drive link. Okay. Now coming to our main lecture, that is the fracture reduction. So fracture, before going to the actual fracture reduction, there is two terms. One is fracture reduction, another is fracture fixation system. Fracture fixation system. So the fracture reduction simply means you are making the apposition. Okay, anatomical apposition. That is fracture reduction. Fracture fixation system means the systems which hold this particular apposition in place. Okay, so fracture reduction, here in this particular diagram you see this particular apposition is fracture reduction, while these wires placed are basically the fracture fixation system. Fracture fixation system has different levels like external coaptation bandage, external skeletal fixator, internal implants under which the pin, the plate and the wires, all those come. We will discuss, this is the core of this orthopedics. We will discuss the fracture fixation system just after one class. Next class will be of bone grafting. After that we will start this fracture fixation system. So the basic difference is reduction and fixation system. Sometimes people use synonymously, but they are not actually same. Reduction simply means you have to reduce the fracture to normal anatomical position, and the fixation system which holds this normal anatomical position. Okay, so coming to our basic class, the fracture reduction. Fracture reduction simply means when you are doing reconstruction or restoration. Okay, right. Reconstruction simply means when you are putting the bone fragments or bone pieces into apposition, normal anatomical apposition. Okay, but this is, you can make this normal anatomical apposition when the fracture is like it is transverse fracture. Okay, transverse fracture or some oblique fractures like this, or transverse displaced or non-displaced fracture, oblique displaced or non-displaced. These are reducible under normal anatomical apposition. There are some fracture like comminuted fracture which are non-reducible. Okay, they are not reducible technically. So what you can do, there is also this fracture reduction applies here. What you can do, you can fix this length. This is the length of this bone. You can fix this length, limb length, through some systems. Here the ESF is used, sometimes the bridging plate is used. So all those are systems through which you will place this limb in normal anatomical limb length, as well as you will fix these joints. Okay, so that this particular length is restored. Okay, we will not do any manipulation to this particular site, it will heal automatically. Okay, but here the primary objective is to make this apposition to stay in its place or anatomical configuration. But here the main objective is to restore this limb length. It will heal automatically. You do not have to do any manipulation to this particular fracture segment. Okay, so that is why reconstruction or restoration of normal limb length and the joints. So these both are coming under fracture reduction. Somewhat you can slightly say that this is kind of normal anatomical, and this is the realignment. You can tell that this is the realignment of limb. Realignment. The better word from restoration is realignment. This is reconstruction. Reconstruction. Okay. So now the coming to the classification, the fracture reduction can be closed reduction as well as open reduction. First we will go for closed reduction. So there are some suitable fractures for closed reduction, like the first one is that this is a green stick fracture. Green stick fracture. These fractures can be reduced closely. Also some oblique fractures or transverse fracture when they are simple, not compounded. Simple fractures. Simple oblique or transverse fractures. Closed reduction can also be possible for severely comminuted non-reducible fracture. Comminuted non-reducible fractures. Okay, when you are doing ESF, external skeletal fracture, same fracture, when we will be doing some implant, internal implant, it will become as open reduction. Okay, so these are suitable fractures. There are some advantage and disadvantage of this particular closed reduction. Closed reduction simply means you will not open this surgically. Okay, so by applying traction force or tractional force, and also the counter tractional force, it means, see, this is fracture, you have to reduce this one. So someone will hold this limb from staple joint and someone will hold from hog joint or some point below, then someone will apply traction, this is counter traction, so that this will become opposed, normal anatomical configuration. Okay, that is traction and counter traction. Sometimes also you have to use some bending forces. There will be some angle of rotation, external or internal, so we have to do this by bending forces, bending or rotational forces like that. But you do not have to open surgically. From outside you have to do all these things. So the advantages are, you see, you are not doing any surgery, so all the soft tissue and vasculature around the fracture segment will be remaining intact. Okay, mostly it will remain. When there will be oblique fracture, there will be some degree of damage, but it is compared to the open reduction, when you are performing some surgery, it is better. Also you are not opening, so the risk of infection to the fracture site is less. Also there will be reduction in operating time, because when you will do operation, additional operating time will be there. But the disadvantage is the accurate reconstruction is not possible always, all the time. Sometimes some transverse fracture you can do some accurate reconstruction, but many of them it is not possible. Okay, so accurate reconstruction is better in the open reduction. So this is closed reduction. Next, coming to the open reduction. This is open reduction. So the suitable fractures are, can you tell which classification of this fracture this one? These are fascial fracture. This is Salter-Harris classification. This is normal, type 1, type 2, type 3, type 4 and type 5. Among these, the type 3 and type 4 are articular fractures. Articular fractures. Okay, the indication for open reduction is articular fractures, as well as those simple fractures which you think that by opening you can do better apposition. Those simple fractures can also be reduced in open reduction. Simple fractures like transverse or oblique fracture, as well as displaced fracture. This is a displaced fracture. This one is non-displaced. Okay, this is non-displaced. Non-displaced. The displacement is in relation to the proximal segment. Okay, this proximal segment is a cranial displaced. Okay, why this displacement occurs? Because of the muscle contraction. When there will be fracture, their muscles will be contracted. Muscle contraction. Due to this, they migrate cranially or caudal. Okay, so the main problem in open reduction is this muscle contraction, to counteract this muscle contraction. Okay, so for this we'll discuss. Okay, don't worry. So this is the displaced fracture. For this also you need open reduction, as well as all those comminuted fractures, severely comminuted fracture which is non-reducible, severely comminuted fractures. Okay, so all those fractures can be done in open method. When here you can place a bridging plate. Okay, when you are planning for internal implants, if you are planning for ESF, that comes under closed reduction, but when you are planning for some internal implants, it comes under the open reduction. So there is some generally advantage and disadvantage. Advantage is proper anatomical reconstruction. You can do proper, except for this particular one, severely communicable. For all other fractures, you can do the anatomical reconstruction, so that there will be minimum callus formation and the fracture will heal better. Also, you can place implant. Okay, when you place implant, then there will be composite load sharing. It means the load will be shared by both implant and the limb. Okay, so that the less pressure or less load will be generated at the fracture site. Okay, so composite load sharing. Composite means fracture segment as well as the implant. Then you can do the bone grafting. In the next class, we will discuss regarding this particular subject, bone grafting, different types of bone grafts. Okay, so when you will do bone grafting, the healing will be much faster. Okay, compared to the normally if you are doing without bone grafting and with bone grafting. In bone grafting, it can heal within 2 weeks also. Okay, so the bone grafting can be done, but there is some disadvantages, like you are providing some surgical trauma. So when you will be providing some surgical trauma, it simply means you will be devitalizing or you will be doing some degree of damage to the nearest soft tissues. Okay, soft tissue and vasculatures. Greater chance of infection because you are opening something, so there will be chance of infections, and there will be additional operating time compared to the closed reduction system. This open reduction system or open reduction method, there are some basic principles. What are those principles? First one is normal separation. Normal separation between these muscles. We'll see an example. Adequate exposure, gentle handling, and prevent trauma, especially to the nerve and vasculatures. The best example we can see that approach to humerus. When there will be diphyseal, suppose there is diphyseal fracture of humerus. Okay, how we can approach the humerus? So first one is the normal separation between muscles. You have to go through the normal separation. So you have to give incision over the diphyses of this particular humerus, left or right hand side. So regarding the adequate exposure, I told you, you see the principal motto behind an incision is adequate exposure. Some surgeons prefer tell that bigger the surgeon, smaller is the incision, but I don't agree with that. Most of the surgeries you cannot perform with small incisions. You need an adequate exposure. Okay, when you will be doing the small incision, there is more soft tissue trauma and more trauma to the vasculature and nerves. So you will give the incision while opening after the cutting through the subcutaneous tissues. Okay, you will find 3 major muscles. This one is the brachiocephalicus. The exactly above we will find the triceps, and between these two is the smaller muscles, that is the brachialis muscles, and 2 important vasculature and the nerves. This is cephalic vein and this particular is the radial nerve. Okay, so first point, let us understand the first point, normal separation between the muscles. So what you have to do, basically you have to reflect this triceps muscles caudally and this brachiocephalicus cranially. When you will separate these two, you will find this smaller muscle, that is the brachialis muscle. Now reflect this brachialis muscle caudally and this brachiocephalicus cranially. When we will reflect the triceps and the brachialis muscle caudally and the brachiocephalicus cranially, you will find the diphysis of the the humerus. So instead of doing this, if you have simply cut through this particular belly of this triceps and the belly of this brachialis muscle, then there is every chance you will lead to radial nerve injury, or when you will cut through the belly, bleeding will be profuse. But when you will do this separation between muscles, bleeding will very minimal. Okay, so this is basically the principle that you should go through the separation between the muscles. Similarly, the femurs, when you have to give the incision on the tensor fasciae lata, the rectus femoris and the triceps muscle and the vastus lateralis. Between those, you have to go through the femur, go to the femur. Okay, So that basically is separation of the muscles and go to the diaphysis or any fracture, mostly the diaphyseal fracture. Similarly, there are some techniques for other fracture, condylar fracture or any joint fracture. There is some anatomical approach to that particular area. So know that. Okay, if you are not knowing all those things, simply keep a book and refer before going to surgery. Okay, it will help you. There is no such thing called an ego, why I should read, I know everything. It's not like that. Simply keep a book. Sometimes people forget. Okay, if you are doing a femur surgery in once in a month, you are supposed to forget. Okay, don't worry, simply refer a book and go for surgery. Okay, so this is basically the anatomical separation between muscle to approach to a bone. And here I told you this is brachial, the cephalic vein and the radial nerve. You have to very careful regarding the injury to this particular vasculature and the nerve. Okay, all the points justified. Separation between muscles, adequate exposure. You have to give the incision slightly large enough. Gentle handling, of course, you know that this is also comes on principle of surgery. So you have to handle very gently, otherwise you may injure those soft tissues. When you will injure those soft tissue, there will be devitalization of the bones. Okay, what is actually devitalization of bone means? You see, there are 4 fragments here, 1 2 3. Okay, this is a proximal segment, this is the distal segment. So when we are doing for apposition, you remove a piece of a bone, then do the apposition by keeping it there. What will happen to this particular bone? Some soft tissue will be attached. To particular these soft tissues, the vasculature will also be attached. When you will be removing that particular piece from that particular area, you will be removing it from the nearby soft tissues. Okay, when you will remove that particular segment is devascularized. Okay, it simply means devitalized. Okay, so understood this concept. This is particularly important for comminuted fracture rather than the oblique or transverse fractures. Okay, so you have to take very take care regarding this devitalization of the bone disease. Next, the open reduction. It can be direct and indirect. First one is the direct. The suitable fractures are basically the transverse fractures, oblique fractures, okay, oblique or spiral fractures, as well as some fracture with some butterfly segment. I have discussed regarding the classification of fracture in the second class, so I will do check that. I will give the link to the orthopedic playlist. So these are the fractures through which you can do the direct reduction. What is direct reduction? There are some techniques regarding the direct reduction. First one, let us discuss that what is the technique for transverse fracture. There are 2 techniques. The first one is in this particular thing. Let me show you in the radiograph. First, let us understand here, then I will show you radiograph. So here what happens, there are 2 fragments. Okay, simply lift those 2 fragments, touch each other, the proximal distal segment, then push it to make it opposed. See this picture here, this particular picture, this is a transverse fracture. What we will do, we will hold this with bone folding forceps. You will hold this one, take from the surgical side towards you, then here is one, here is one. Okay, here is one. So what you will do, you will hold these segments with the bone holding forceps or anything or any forceps. You have to take out, okay, or lift up, then touch this and then just simply push it back so that there will be apposition. Okay, that is fracture reduction. Next, another technique is you can use you can say the periosteal elevator, or you can use a BP bed handle. Okay, simply it means it is a lever, it acts as a lever. Okay, you will use a lever. You see here one fragment, between these you have put this lever. So when you will move this lever like this particular segment will go up, this particular segment will go down, and there will be apposition. Then simply remove the lever. Anything you can use periosteal elevator, scalpel bed handle, all those things you can. This is also another method through which the transverse fractures can be reduced. Okay, why this needed? I told you, the main problem is the muscle contraction. So you need some degree of, you see, this muscle contraction will do the or will cause the bone fragments to come closer like this. Okay, so that is why they are displaced cranially or caudally. So what we are basically doing, you are distracting. This is the distraction. You are distracting this fracture segment so that they will come into the opposition. This is the basic thing. Okay, you have to counter the muscle contraction with distraction. By physical force, you have to distract those segments. Okay, the proximal segment and the distal segment. Next is the oblique fracture. How you can reduce oblique fracture? Okay, in case of oblique fracture, you have to hold these bone segment fragments. You see, for particularly muscle contraction, counter muscle and contraction, there is a tip. You can use any anesthetic or pre-anesthetic which causes excellent muscle contraction, so that this particular distraction step can become little easier. There are some agents like that alpha 2 agonist. They are excellent muscle relaxator agonist, like Jalexin, dexmedetomidine, medetomidine. Okay, all those are excellent muscle relaxation. Another is benzodiazepines. Okay, like diazepam and midazolam. All those are good muscle relaxation. So if you are incorporating these things in your anesthetic protocol, then it becomes little easier. Let us come to our own chapter. The oblique fracture reduction. What you can do? You have to hold the proximal segment and distal segment with one holding forceps. Then you have to distract. Okay, you have to distract at the same time. You have to make this apposition. Okay, so when you will be little closer, you can use a towel clamp or any holding forceps to make it appost. Usually it will not appost. You have to do further distraction with the bone holding aspect, and there will be an assistant who will be further clamping this one, tightly clamping. So there will come a stage when it will be tightly clamped. Then you can do whatever procedure you are doing, whether you are doing IM pinning or you are doing circlage wearing or you are doing the combination. All those things you can do. This is basically the fracture reduction. This is reduction. When you will doing wearing or plating or pinning, those are fracture fixation systems. Okay. Next, there is also another possibility that there may be oblique fracture, but oblique fracture might have some fissures. These are fissure lines. So for those, you have to first do some wearing, circlage wearing, to fix those fissures and repeat the procedure like the previous one. Similarly, also when there will be a butterfly segment, this is a butterfly segment. So first you have to oppose these two and you have to fix with wires, then do the other one. Okay, these two first fix, then these two. Okay, so there is nothing much like some big thing, but this is physically adjusting. Orthopedic is a physical surgery. You need to be slightly more powerful for doing these surgeries. Okay, so this is oblique fracture reduction. Now coming to the indirect method. Indirect method is basically used for comminuted fractures. It is basically used for comminuted fracture which are non-reducible. Comminuted non-reducible fracture. Okay. Here the principle is basically to majorly, you see this particular segment is comminuted. This is the proximal segment, this is the distal segment. Okay, here the principle is when there will be comminuted fracture, it will also be contracted. So what is the best principle is, I told you the best principle for comminuted fracture is realignment. So what here we the basic objective is actually this proximal segment and distal segment, it should be distracted. These particular two segments will be distracted if at all contracted, and this particular segment will not be touched. The technique is open but do not touch. Open but do not touch. Do not touch. So this particular distraction is basically the indirect open reduction technique. Okay, so there is also another technique, though when we will go for plate we will understand plating. There is a known as bridging osteosynthesis. This concept is applied to this comminuted non-reducible fractures. What you will do here, after the distraction, when you will see there are two methods of distraction this particular comminuted non-reducible fracture. So after this distraction, you have to put a plate here. This particular plate is a bridging plate. I have discussed this bridging plate in the first class. Okay, here the name bridging plate is given because it acts as a bridge to transfer this axial load pressure from proximal segment to distal segment. It will bypass this particular area. So when this particular area will not be disturbed, there will be osteosynthesis. Osteosynthesis. So this concept is bridging osteosynthesis. Though this term looks like some heavy term, but is not. Okay, when you understand some concepts, then terminology don't bother you much. Okay, let us go to our techniques. So what are the techniques? There are two techniques. First technique is when you use an IM pin. IM pin. The second technique is when you use the patient's own weight. The patient's own weight. So how it is done? Regarding the IM pin technique, this is an intramedullary pinning technique. Here you see there is fracture and there is some degree of contraction of this. This is proximal segment. This is proximal segment and this is the distal segment. And this is the comminuted fracture. This cannot be reduced. So what you can do? First, whether you are doing normograde or retrograde, let us make it normograde so that you can understand better. Otherwise, you can do retrograde also. So when you suppose doing normograde, you have inserted the pin here to the proximal segment. We will pass through this one. Here, let me show you because it is already reconstructed or realigned so that you can understand here. You have to put the pin in the proximal segment, pass through this particular comminuted fracture, then you go through the distal, and here this is epiphysis, this is physis which is growth plate, this is the metaphysis. When it will touch the metaphysis through, when you will be drilling, you can feel this one. So when it will touch this metaphysis, what you have to do, you have to hold this proximal segment with a bone holding person. This is a bone holding person, you have to hold this one. It means you are simply fixing this particular proximal segment. Then you have to drill. During the drilling, it will exert force on the distal segment. So this distal segment will be distracted. Now this particular segment will be distracted towards the distal segment. Okay, like here you can see that this is fixed. When you will be drilling this particular distal segment at the metaphysis, it will put some pressure and it will be distracted, and there will be normal limb length. Okay, normal limb length will be attached. After this, you can use a plate or anything if you want to do. Okay, after that you can also remove the rod, or you can do the plate rod technique. Whatever you need to do it. Simply first step is distraction, that is the reduction. Okay, distraction is not reduction, it is part of reduction. So first you have reduced this one by using a IM pin, then you do whatever fixation system you need to do. Otherwise, what you can do, this is the second technique in which the patient's own weight can act as the force to reduce this particular fracture, or you can say distract the proximal and distal segments. Here you have to suspend the limb, the affected limb, from the ceiling. This is the ceiling from which you have suspended. Put the patient on this operating table. Nowadays, modern operating table coming with the hydraulics. So, okay, so when they are particularly suspended and it is tensely put, this is in tense condition, simply lower this particular operating table with hydraulics. When this particular table will be lowered, the patient body weight will go down, okay, due to gravity, of course. So when it will go down, this particular segment can be distracted. This proximal and distal segment, it can be distracted from each other, and there will be reduction or apposition of the bone. In comminuted, it is not apposition, but the normal limb length or realignment can be done very nicely. Okay, these are two techniques, that is the IM pin technique and the using patient's own weight. Okay, these are two techniques through which you can do you can reduce the comminuted non-reducible fracture. Okay, so this is all about the fracture reduction. The notes are in the description. After this class, do check them out. You can say simply a revision. Okay, in the next class we will be discussing the bone grafts. Okay, there are some research regarding bone grafts also. After that, we will start the core of the orthopedics, that is the fixation systems. Okay, so till then, tata, bye bye, take care.